welcome to the Home of Medicine podcast with me, Dr. Amy Burbridge. I'm a consultant in acute and general medicine working in the West Midlands. And today I am very excited and delighted to be joined by...
Hi everyone, my name's Nicola Cooper. I'm a consultant in acute medicine and I'm based in Derby. I'm also a clinical associate professor in medical education with a specific interest in clinical reasoning and how people learn.
Thank you so much for joining me. Honestly, it's an absolute honour. So I'm just going to tell the listeners a little story about really, I guess, what got me into clinical reasoning and even making this podcast. So way back when we were trying to figure it out, but I think it was 2015, 2016. I was at a general internal medicine training day in the West Midlands and Nicola was there and she did a session on clinical reasoning. And I genuinely believe it changed the course of my career because up until that point, I didn't really know what clinical reasoning was. And it was like a penny had dropped and I was like, oh my word, this is what medicine's all about. And from that day onwards, clinical reasoning has become a massive part of my day-to-day discussions. People at work, I'm sure, are fed up of me talking about it. And a couple of years after this teaching session, I made quite a big medical error. And one of the things that helped me, I guess, assimilate where I'd gone wrong and move forward was this original lecture, Clinical Reasoning and Cognitive Bias. So a massive thank you for that. And I guess we'll start with a case.
Thank you. And that's a really amazing story as well, which I didn't know until today.
Yeah. So I'm going to start with a case. And the way that this is going to work today for the listeners is I really want to figure out what's going on in Nicola's brain when she sees a patient, because I think we can all learn a huge amount. So I'm going to set the scene. This was yesterday. So I did quite a busy day at work yesterday. It was a 12-hour shift. And I picked up some notes of a 68-year-old male. Now, he'd already been seen by the medical registrar, so he was a post-take ward-round patient for me. And I read the notes and the history was quite brief. It said suprapubic pain, known to have prostate cancer with metastases to the bone. He denied any urinary symptoms. There was no dysuria, no frequency, no urgency. But because of the suprapubic pain, he'd been started on intravenous antibiotics and coamoxiclav. The diagnosis was urinary tract infection, most likely urinary sepsis, plan for intravenous antibiotics, coamoxiclav, and for post-take ward-round review. So, first of all, what's going on in your head when you're looking at notes like that?
This is really interesting because, there are some consultant colleagues who, if a patient's already been seen by the med reg, they'll just kind of move on. Because what we do is cognitively very difficult actually, and if someone's already been seen by a good enough person, then let's just rubber stamp it and move on to the next case. Who cares, right? But actually, and this is quite fascinating because we all vary in our tendency to be skeptical. There's a fantastic body of work by a psychologist called Stanovich and his colleagues. They're based in Canada, and they research rationality. I've been reading a lot about their work because that informed a lot of the second edition, actually, of the ABC of clinical reasoning. And I'm interested in individual variation in particular, why people with the same level of education and qualifications vary so much in their performance and decision-making. We see that among med regis and consultants, for example, don't we? And it's really fascinating in psychology. Once you've accounted for knowledge, IQ, so once you've accounted for that, the reason why people vary so much in their individual performance on reasoning tasks is their cognitive style. And that is your tendency to think about your own thinking, to be aware of context, to look things up, look for evidence, seek advice, that type of thing. So I'm aware when I'm answering this question, I'm answering it as me because I have a particular cognitive style. I'm very skeptical and reflective and likely to look things up and all that kind of thing. So I can just see me reading this clerk in and just kind of my steam starting to come out of my ears for a few reasons. So the first thing is, you know, just because you've been seen by a med reg doesn't mean that it's correct. And things are particularly sticky when a consultant has already seen the patient, isn't it? That makes it even worse. Also, probably you're doing a morning ward round, right? And of course, the med reg has been operating under night brain, what I call night brain. And actually, there was a beautiful, a nice little letter published in Nature in 1997. I can't remember the author, but they basically, it was a funny experiment. They showed that your performance at 4 a.m., if you've not slept, 50% of people don't sleep before the first night shift. And if you've not slept before that first night shift, by 4 a.m., your performance is equivalent to 100 milligrams of alcohol in your blood. So you're basically a drunk driver, yeah? Drunk senior review. It was a study in Australia with obs and gynae registrars. Half of them they fed alcohol to every so often, and the other half they did the night shift, and they did, you know, cognitive tests on them and reaction times and whatnot. So I'm looking at this thinking, okay, night brain. I'm a naturally skeptical person, and there's some things that don't add up at all here. So he's got no urinary symptoms at all, but he's got this suprapubic pain. He's got prostate cancer with bone mets. He's on IV antibiotics. I'd be looking at the CRP and the white cell count, and then of course this terrible phrase urinary sepsis, which is banned if I'm around because yeah. And I spent ages trying to explain what is sepsis and what is not sepsis. But things that are going through my mind, I think it's really important to think, who is my patient?
Yeah.
And in fact, Manchester Medical School have got a lovely clinical reasoning tool they use with their students. And the first step is, who's my patient? Humans are very bad at estimating probability. We really anchor on the story. We have what's called story bias. Actually, the news journalists use that all the time, don't they? They don't tell us stats. They get an individual to tell their story. So we're very prone to story bias, and we're very bad at probability. And actually, to be more accurate in thinking about what the diagnosis could be, we're really meant to anchor on who is my patient and then adjust for the story. But we actually do it the other way around. So if we try that with this case, who is my patient? So we've got a guy with prostate cancer.
Yeah.
And bone mets, okay? And he's come with suprapubic pain. Now, I need to think, okay, so what could be the causes of suprapubic pain in a guy with prostate cancer? So the first thing's going through my mind is, okay, is he in retention? And remember, you can be in retention and still pee small amounts. People forget that. So I would be going with a goal in mind. And I always try and tell my registrars, when you've read the notes, you need to go with some goals that you're going to... And actually, they find this really difficult. And I think it's maybe because their knowledge might be a problem, but I'm going now to see this patient with some goals in mind, which is along the lines of, you know, for now, I don't believe he has an infection until I've seen evidence of raised inflammatory markers and whatnot. And I'm going to either scan his bladder or palpate his bladder to see if he's in retention. So just on the info you give me, these are the kind of things I'm sort of thinking about, really. But I'm skeptical, and I want to go and find out for myself. Okay. I want to know the story, because it seems to be a bit scanty, this history, isn't it? Why would you come to hospital with suprapubic pain, for starters?
Yeah. And
there's some missing info here.
There's loads of missing. Yeah, absolutely. And you're absolutely right about the night brain. When you're taking that history in the middle of the night, it's very different to that morning brain, isn't it? Yeah. I'm also very skeptical. And I think that stems from a medical error that I made quite a few years ago, where I basically anchored onto the first piece of information I was given from previous doctors, paramedics, GP, and the bias of diagnostic momentum. The diagnosis had been made and I couldn't question it, and I messed up. And ever since then, I think I've become the slowest post-take ward round consultant in acute medicine, because I always have to go back to the beginning. Not because I don't trust other people, but because I don't want to be in that situation again where I made such a big medical error that resulted in me having to take time off work and really question, was I in the right job? So now I really am very slow, or thorough, I like to say, maybe.
You know what, Amy, that's really interesting, because there's research that shows that experts spend longer representing the problem than learners do. So people may notice, you know, listeners may notice that the consultants can be a bit annoying sometimes, right? Because you're trying to present the case, but they're like flicking through and sort of ignoring what you're saying. And they're really interested in why the patient is here in the first place.
Yes.
They're kind of ignoring things. They want to know where the ambulance sheet is. Can I see
love
the
that
GP
ambulance
letter?
sheet.
Yeah.
Yeah.
The poor old junior doctor's trying to present the case from their notes, and you're like, where's the ambulance sheet? Where's the GP? You know, and that's, you know, have you phoned the care home? That type of thing. And that's actually because, and this is in lots of different domains, experts spend longer representing the problem. So that's how so problem representation is a whole thing. So you see, clinical reasoning involves memory, which is of course knowledge, memory, decision making, problem solving, and there's a whole branch of psychology to do with problem solving.
Yeah.
But anyway, but experts spend longer really figuring out what the problem is, and then they solve it dead quickly. Whereas learners or novices will actually gloss over the problem representation stage and then proceed to solve the problem more slowly, but make many errors and often have to go back to the beginning again. So actually getting to the bottom of why this person is really here today is a function of actually what experts tend to do anyway. And there's a lovely article, and I can't remember the author again, but it's in a MedEd journal. But it's something along the lines of a new model of expertise, slowing down when you should. And what's interesting from the clinical reasoning literature is that there is no one way of thinking and decision making that's better than another. As you know, sometimes we'll just make a spot diagnosis, sometimes we'll just know, sometimes we have to go back to first principles and think it through. Sometimes we just have to triage because we've got a massive humanity that we have to fix in priority, you know. So there's no one way of thinking and decision making that's better than another. But what experts are good at is slowing down when they should, and just being good enough when a good enough response is all that's needed for that particular situation. And it takes a while to learn how to change your gear in that way. Some people find it easier than others. But yeah, so when you say that, you know, I think that's, you know, some of what's going on.
One of the questions that I always like to ask a patient as well is, first of all, why did you come to hospital? But also, why did you come to hospital today and not yesterday if you've had the problem for 3 weeks, for example? Yeah. So in acute medicine, we get a lot of patients who may have had a headache for 6 weeks, may have had a suprapubic discomfort for 4 days. But what is it about today at 9 o'clock that made you go, I'm going to go to hospital today?
I think that's such a useful question, because the question is either, oh, my wife nagged me and I gave in.
Yes.
Or it's this bombshell like, oh, well, it was because I collapsed. And you're like, what? Because that's not anywhere.
Yeah, that's a really good point. Yeah. So I'll tell you a little bit more information. So when I reviewed the patient's notes, I was a bit skeptical. And I looked at his blood tests with the doctor I was on with on my day. And we noticed that his white cell count was 17.61. So pretty high. His neutrophil count was 16.55. His CRP was 41. So consistent with an inflammatory process, whether that be an infective inflammatory process or a non-infective, we're not sure at the moment. But I was thinking, okay, could this be a UTI? Potentially. So I then looked at his kidney function and it was normal. So that was reassuring. Sort of could still be in retention, but there was sort of I guess there would be no hydronephrosis with a normal kidney function. So that was reassuring. And interestingly, I don't know whether this is a good thing to do or not, to look at the bloods before you go and see a patient, because I know there's a debate about that as well, whether that skews your decision-making process. But I looked at his liver function tests and his alkaline phosphatase was 360. So the range in our hospital is 30 to 130. So that's pretty high. His ALT was 157 and the range was 10 to 49. And his bilirubin was 82. And again, in our hospital, the normal range is less than 21. So I was like, whoa, okay. So on further reading of the nighttime notes, it's documented that abnormal liver function tests most likely sepsis-induced hypotension, ischemia of the liver. Okay, that could happen. But it got me thinking, could there be something else going on here? So I went and spoke to the patient. And I went in to see him and he had 3 family members present. And they said, should I leave? And I was like, no, I always find having family members, they're really helpful. Not in all situations, but mostly. So I started to ask him questions, and he said he'd got some generalized abdominal pain. So it wasn't necessarily suprapubic, but he was just sort of waving his hands all over. No radiation of pain. He said that he hadn't had a poo for 4 days and he felt constipated, and that he'd actually been vomiting. And the day before admission, he'd vomited 4 times, but was no longer feeling nauseated. His daughter said that he'd been having hot and cold sweats. Because I asked the patient, have you had any fevers, been feeling hot? And he said, no, nothing like that. And his daughter was like, yes, you have, Dad. You've been hot and cold. Last night you said you couldn't sleep because you were so sweaty and hot in bed. He then said he hadn't had much of an appetite for a few days. And then his family then said, oh, actually, it might be a bit longer than a few days. It could be a few weeks. He just said he didn't feel like eating. So any thoughts now?
So it's interesting that, isn't it? I mean, clinical reasoning is highly dependent on knowledge. We know that. But actually, it's really important to understand that by knowledge, we don't just mean facts, yeah? Because you can know a lot of facts and not understand how facts and ideas fit together conceptually. And also knowledge includes how to go about things, and also, those kind of things as well. So just, I'm saying that as a comment about this shock liver business, because that's, I think that's a load of rubbish. And the reason why is that's usually associated with, usually the ALT, I think in the thousands, like over 4,000 or something like that. And, a proper episode of proper hypertension and proper sick patient, like an ICU type patient, not this patient that we're talking about. So I think that's a weird thing well, it's not a weird thing to write. It's a normal learning behavior, isn't it? It's a mistake. It's wrong. And, but, so, and it's interesting. So he's got generalized abdomen. So now what I'm thinking, what's his calcium? Because I'm thinking about, abdominal pain and vomiting and constipation, and he's got bone mets, yeah. But then clearly there's some, probably some infection going on, because I don't think just having cancer would normally, I mean, it can do, but we can look back his old results, but probably, hopefully, if we looked back, he's got a new neutrophilia and a raised CRP. Now, of course, cancer patients can have cancer things, but they also get normal things. And if he was a normal guy, we'd think, has he got, cholangitis or, a biliary infection, basically, wouldn't we?
Yeah.
So these are the kind of things, really. And I'd be thinking, okay, well, and of course, in medicine, when things are a bit vague, we go where the money is, don't we?
Absolutely.
So we just need to ultrasound his liver and maybe take some blood cultures. So that's sort of what would be going through my mind. And what you said about family is so important as well, is that sometimes they appear just at the right moment. And you do get the best answers, because they observe things that the patient might not clock themselves. Yeah.
So I absolutely went down the same route of thinking that this must be biliary, because of the abnormal liver function tests, the raised white cell count, generalized abdominal pain. So I thought this must be biliary infection. So I started to ask him about, I started to lead him, which I shouldn't have done. So I said to him, when you eat some fatty food, like a cream cake or a chip butty, and he was like, well, I don't eat any of those things. And I was like, okay, so if you eat something fatty, do you get indigestion? Do you get abdominal pain? Does it make it worse? And he said, I don't eat any fatty food. In fact, I've lost quite a lot of weight over the last few months. And the family chipped in and said, yes, he has lost quite a lot of weight, actually. Couldn't quantify, but his clothes were quite baggy. And I said to him, so why do you think you're losing weight? Why aren't you eating? And he was just like, I just don't feel like eating. So I was like, it must be a gallstone. I was like, do you get any indigestion? I asked him again, anything at all? Do you get any funny taste in your mouth when you've eaten? And he was like, no. So what on earth is going on? So I could really feel myself trying to lead him down that, because I was like, what on earth else could be going on here?
That's the interesting thing, isn't it? Because on the one hand, you want to hone in on what you think the problem might be by exploring it. But on the other hand, you've got to keep an open mind about all other things it could be. So, for example, if he didn't have prostate cancer, we'd think this guy had cancer as well, wouldn't we?
Exactly.
We'd be thinking about pancreatic cancer or some kind of upper GI cancer, which presents with all of these symptoms, doesn't it?
Mm-hmm.
And sometimes it's, especially the way exams are written, the way exams, MRCP, everyone's only really got one thing wrong with them, don't they? But that's not real, is it? I remember seeing a third year medical student get really confused because she went to see a patient with both right heart failure, with LVF, I think, LVF, but also had a bowel obstruction. And it really confused her because she wasn't expecting a resonant abdomen, you know, she was expecting ascites. And when I said, do you think the patient might have more than one thing wrong with them? The look of confusion. So yes, we can be MRCP'd into thinking about this case.
Yeah.
You know
Do you know what? That's what I did, I think. So I don't know how many patients I'd already seen in the day, but I went down that route of he can't have two cancers because that'd be really unlucky. And I sort of I sometimes get myself thinking that, well, I don't want him to have that because that's really rubbish. So it can't be. And I know that sounds crazy, but then you start to think, well, I don't want to diagnose that because that's not very nice for the patient or the family. And obviously I check in on myself and go, come on, Amy, be reasonable. That's not the right way to think. But I did, to be honest, pancreatic cancer did not even enter my head. I was convinced this must be biliary infection because of the abnormal white cell count, the CRP, and the abnormal liver function tests. And I examined him, and his pulse was completely normal, 80 beats per minute. He had a normal blood pressure. He looked jaundiced. And I said to him, do you think your skin's changed colour? He said no, but all his family had commented that he had. I examined his heart. It was normal. Chest was clear. When I palpated his abdomen, I didn't feel anything. It was nice and soft, non-tender, bowel sounds present. There was no tenderness in the right upper quadrant, suggestive of cholangitis. It was a completely normal abdomen. I examined his legs and there was a very small amount of edema. Calves were nice and soft and non-tender. So I sat down and very confidently said, so there could be a couple of things going on here. I'm not entirely sure what it is yet. We need to do some more tests. However, I'm not convinced this is a water infection. But I think you may have a gallbladder infection. You may have had a gallstone that's got infected. And his daughter went, well, that's strange. He had his gallbladder taken out in 2017. And I was like, oh no, okay.
I mean, that's just really interesting. There's a few things there that are just really fascinating. The first thing is, I don't think we're very good at teaching evidence-based physical exam. I mean, just because I think, there's a guy called Eric Holmboe who works for the American College of Physicians, I think, and he writes about the fact that there are well-documented deficiencies in trainees' physical exam skills. I think for new doctors, they will miss 1 in 4 important findings or invent 1 in 4 important findings that will change the diagnosis. So he talks about how important it is for us to watch people, and observe our trainees and stuff. But we, although we teach physical exam, we don't really teach what I call evidence-based physical exam. So that's how good things are when you find them. And so trainees and often consultants will have this idea, for example, that if everything, maybe I'm just giving an example. Let's say we've got a query PE or something, the amount of times people come up to me and say, well, I thought about PE, but the SATs are normal and she had no chest pain. So that's a classic of, you don't actually know how PE presents. And that's partly because the way it's presented in textbooks and the way it's presented in our postgrad exams, it's all prototypes. It's not how people present in the 21st century. So, you're talking about his normal physical exam. To me, when you were saying that, I was thinking to myself what I would do. I would discount the normal physical exam as irrelevant because actually we've got this history. And I think that's so key sometimes. I mean, even with the explosion of medical technology in the last 30 years, history is, at least in medical outpatient settings, the studies are, it's still the majority, over 70% of how we make a diagnosis. Your hypothesis testing in physical exam, aren't you? But we've still got this incredibly valuable history. And so I would say that, that physical exam's added nothing. It's not taken away or added anything. Whereas I know that some learners will put great weight on the normal physical exam, inappropriately, for example. And then the other thing he said about his gallbladder being removed, and I remember I was a gastro-reg for a year as part of my gen med going back years. And I didn't know you can get gallstones after you've had a cholecystectomy. I remember my consult. This is when it dawned on me. I was presenting a case to my consultant, and he was trying to explain you can still get gallstones after you've had a cholecystectomy. And I just looked at him and I said, "But where does the bile come from?" And he just looked at me with a deadpan face, and he went, "The liver." I'd forgotten my first year, second year medical school. But anyway.
Yeah.
But yes, I have seen consultants say, "Oh, you can't have gallstones, you've had your gallbladder removed." That's what the daughter was saying, wasn't it? In fact,
absolutely.
That's not true.
Yeah. So I had this similar conversation yesterday with the family, and the trainee I was with, and said, well, actually, you can still get gallstones, even if the gallbladder's been removed. But I did feel like a bit of a wally, to be honest. I was really confident about this diagnosis. And then I really then started to second guess, third guess, fourth guess my diagnosis. So I said, oh, just give me a minute, left the bedside and said, I'll be back, and then just checked the operation notes. And I wanted to go back and have a look what operation it had done, what had they found, anything like that, just to be entirely sure what I was going to talk about. So yes, he had his gallbladder removed in 2017. There'd been no complications. So actually, yes, you're right, could potentially still have a gallstone. So, however, by now, the diagnosis of pancreatic malignancy came into my mind, because I went, do you know what? I'm just going to ignore the previous diagnosis of the prostatic cancer and go, okay, so now we've got this gentleman who's got an obstructive picture on his liver function tests. So we're still on paper and pen at work. So I write a problem list, and I wrote in it obstructive jaundice, and I do like little spider diagrams in the notes. Yeah. And a line off that was pancreatic malignancy. Another line was gallstones. And then I thought, okay, could it be hepatic jaundice? So a few causes there, could this be EBV? Could it be CMV? Potentially. But, these are all sort of things that were going through my head. So then I had to completely change my plan then when I went back to see the patient again.
And actually, do you know what you've said there has just reminded me of something that's really powerful, and we don't talk about it, and that's problem representation. We've done a whole chapter on this in the second edition of the ABC of clinical reasoning, because it's just so incredible. So problem representation is a thing in medicine, but we don't talk about it. And it's basically, probably sometimes it might be best summed up as the impression, but it's not a summary, and it's not the PC or the HPC again. It's an absolutely stripped down key features of the case, but the language you use really matters. And this is this is the fascinating part, because whether you're a student or an expert, if you represent the problem using very precise medical language, and you use what's called semantic qualifiers, so these are these binary descriptors we use in medicine: poly, mono, unilateral, bilateral, progressive, intermittent, acute, chronic. Or so you use precise language, you use these descriptors, or you just put things together in a syndrome, if that's relevant. If you use this precise language, your diagnostic performance is really high compared to, check this out in studies, near zero for people who just kind of waffle. And this is absolutely fascinating to me, because language and memory are really heavily intertwined. And by translating the patient's own words and the data that you gathered from the patient and the relatives and the bloods and all that, by translating all of that into this precise medical language, that's how we're matching the patient's data with illness scripts and our long-term memory. So I'll give you a really cool example. If you've got some medical students and you've just been to see a patient with chest pain, and the patient summarised the problem as chest pain, when you say to the students, what do you think it might be? I bet you 100% of the time, the first thing that will come out of their mouth is ACS, heart attack or angina. Because whenever you say chest pain to students, they say heart attack. Yeah. But the patient you've just been to see, was a 30-year-old woman with left side, an acute 24-hour history of left-sided pleuritic chest pain and breathlessness. if you get the students to represent the problem like that, they would never say heart attack or ACE. They'll come up with really sensible things like PE and pneumonia and all that. And that's because they have the knowledge. It's just that they're not able to access the knowledge that's already in long-term memory because of the way they're representing the problem. So it only works when the case is complex. It doesn't work when it's a dead straightforward case. But when the case is complex, doing a problem representation before coming up with diagnoses is so powerful. And if we were to represent the problem here, because it's usually who is my patient, followed by relevant past history, and then the stripped key features of the case. So if we did the problem representation, we're going to have something like 68-year-old man with a past medical history of metastatic prostate cancer, with, you know, an X-week history of anorexia, weight loss, nausea and vomiting, and new obstructive LFTs. We're probably going to say something like that, aren't we? And that immediately gets your brain thinking about all the things you know that could be. So the time course, you know, and all those symptoms lumped together makes you start thinking maybe less infection and more cancer, because you have that illness script in your long-term memory already about how pancreatic cancer presents, you know, for example, and it makes you think about it. Whereas if you just take the history and examine the patient, look at the test, and then start thinking about diagnoses, it's you can just end up, you know, missing some things that you already know about. But that problem representation is dead helpful when the case is a bit complex.
Yeah.
I think that's something we really need to teach, but we don't seem to. We just teach history exam. What's your diagnosis? Don't we? Give us your differential diagnosis. So yeah.
And that, I mean, when you detailed that problem representation, then the first thing that came to mind was this is pancreatic carcinoma. However, when I first saw the notes and I took the history and I'd looked at everything, I couldn't, for some reason, it wasn't entering my head until I allowed it to, I guess. And then I really questioned it. Sometimes it's about taking a step back from the patient when I was examining him, and I looked at him through different eyes, and I didn't look at him through the water infection eyes or the, you know, the biliary infection. I looked at him and went, actually, he's jaundice. He looks frail. He looks a little bit cachectic. I can see his cheekbones. He looked like somebody who could potentially have a malignancy. And I just completely changed the way that I was viewing the...
Made more complex by the fact that he already has a malignancy.
Exactly. Yeah. And that was what was throwing me. And is it Hickham's dictum? Patients can have as many diseases as they damn well please. And I think we often do that. You know, you're like, we've got one's enough. You know, it's really unfortunate to have two, and three would be really unlucky. So actually, after I'd seen him and had a conversation with the family, I said, this could be infection because he's still got the raised white cell count. He's still got the neutrophil and the CRP. So yes, we do need to do an ultrasound of the liver and the remaining gallbladder or the biliary tree, whatever's left of it. But actually, I also want to do a CT scan because I actually want to look at, is there something else like a malignancy going on here that I can't miss? I don't know. This was yesterday. We'd requested the scan, but it wasn't done. So, I mean, obviously we'll be waiting for the report on that. But it was a really interesting case on how I went from one thing to something completely different.
And it's fascinating as well how the registrar had sort of come up with shock liver and neurosepsis and all that. And actually this really reminds me of there's this thing in education. I've been reading about it recently called the cognitive apprenticeship. And of course, we really don't set up our education systems to enhance clinical reasoning education, do we? Because it's so difficult now to get feedback. I mean, I know a lot of us will have that hour where the night team can go around with the weird cases that they've seen. But, you know, very often by the time you've done a handover and the night team look, you know, knackered, off they go. And, you know, of course, our ward round takes all morning, doesn't it? And trainees, depending on your IT system, and also the motivation and the curiosity and the cognitive style of the trainee, they won't be tracking patient outcomes themselves. We need to build feedback into the education system, into our IT systems and into our education system in a way that's sort of feasible. Because actually, cognitive apprenticeship is where we kind of make our own thinking transparent, but also we correct, you know, knowledge gaps. So we'll talk about, you know, actually, how does a shock liver present? Because it's what I find is that a lot of our junior doctors, they've read about stuff, but they've never seen it, which probably explains why there's so many cases of encephalitis around, which is not encephalitis. Don't know if you have this problem, but I remember going to see a patient, and it was a mysterious case the night team had seen, and so we went to A&E to see this patient, and I just said, this is not encephalitis. You need to stop all of this, but he's probably got a demyelinating condition. Like this weird thing, AEDEM, this acute demyelinating encephalo, whatever it's called, which is what he turned out to have. And then we were walking back, and I just said, have you ever seen infectious encephalitis? And the SHO said no. And I said, well, that's the thing, you don't have an illness script for it. You don't know what it looks like. And illness scripts are very important. We know that, so an illness script is that tightly compiled knowledge and long-term memory that's a mixture of your formal study and all the cases you've seen. They're often incomplete. We're continually adding to them. They may be incorrect, but they're always being refined over time. And we know from the clinical reasoning literature is that experts are not experts because they have bigger brains or bigger memories, or they're better problem solvers in some ways. They use different strategies to novices. They don't. But it's the richness of their illness scripts. It's the organization of their knowledge and long-term memory. And that's why it's so important to just see as many cases as possible in as many different contexts as possible. That's how people get good. But with the coaching and the feedback, you see. So, so this registrar would be for that person to then have this conversation about, well, actually, you've probably never seen a shock liver. Let me tell you how it presents. And also for us to be understanding about, night shift work. And night shift work is completely different. Family not there. You just basically try to keep people alive. So we've got to make it as this kind of safe, we're here to learn. Because, I've done nights recently, with the junior doctor strikes. You're literally just making sure things are safe. You're not dotting the I's and crossing the T's. And every consultant needs to understand that in the morning when you're at handover. Never criticize the night team.
Yeah, absolutely. I remember when I was doing nights as a reg and being criticised for not picking up, weird diagnoses. And I'm like, it was 3 a.m, the patient was asleep. And often that's the difficulty as well, is the patient's fast asleep. You don't want to wake up.
That's why we go around in the morning again, because, that's when we do the weird and wonderful stuff. Meanwhile, the registrar has been sending people to ICU and resuscitating people, and they've all gone by the time we turn up because they've,
exactly.
been busy up.
Yeah, they're the ones fighting the fires, aren't they, in recess all night? Yeah. What you mentioned, and I think is really important, but I've noticed that not many people do it, is I follow all of the patients I see. So every patient I saw yesterday, I have a list at work. I have all of their hospital numbers, and I will follow them all up to identify investigations. Was my diagnosis right? Was it incorrect? Did I do the right thing? Did I do the wrong thing? Because how else am I going to learn? And I mentioned it to a trainee the other day, and I said, this is a really good case. I would follow this case up. And they were like, oh, do you do that? And I was like, I do with all of them. Sometimes it might just be a quick review of the troponin was negative. It wasn't ACS. Or it could be something more complex. So, for example, this individual, I will follow up on that CT. I will identify what was going on in that pancreas and the cause of those abnormal liver function tests. So I think that's something we need to teach, is the importance of following up on the patients and the cases we see.
Yes, and this is where hospital IT is important as well. We used to have an IT system where we could add to our list, and now we have an IT system where we can't. And so that actually is quite important. There's a really nice paper published in the Journal of Graduate Medical Education, and it's called, it's by Murthy et al. It's called An Inquiry into the Early Careers of Master Clinicians. I came across this paper a couple of years ago. When was it published? 2018. And what they did was they looked at 17 members, this is in the US, that apparently in this particular university, they have this, the Department of Medicine has a council of master clinicians. So I guess what they do is they kind of recognize the people who are meant to be great physicians, basically. What they did was they interviewed them. They basically asked them what they did when they were trainees. And what was absolutely fascinating, they had these 4 themes. And I always share this with my registrars, actually. The first theme was that they actually had made consistent learning efforts. They read. If you ask your registrars how much they read, They read, they taught, and they followed up their patient outcomes. So that's absolutely fascinating. The second theme was really interesting. They sought to cultivate it says they cultivated habits of mind. So they were consciously practiced humanism and empathy. They were humble. They thought and reflected over their cases. So I thought that was interesting. Another theme was they worked in high volume, clinically rich environments, which is really interesting. Another theme was they really worked on their clinical reasoning skills, like evidence-based history and exam I was talking about before, that kind of thing. And I think the last one was they worked in these rich environments. They practiced outside their comfort zone. They sought out role models. It's a really fascinating paper. I share it with all my registrars and I say, look, most of us will become experienced non-experts. That's what the literature shows. In the words of Erickson, who's an expert on experts, many people achieve this state of when they can do things automatically. And I quote, they maintain this mediocre status for the rest of their careers, end quote. But some of us will become experts. Some of us want to become experts. And that involves deliberate practice. It involves effort. Deliberate practice is a theory that Erickson coined. And it involves being out of your comfort zone. It involves effort. It involves work. It involves coaching. And it involves feedback as well. And of course, feedback can happen from what happened next as well as from the teacher and all that. So I'm a firm believer that we need to teach people how to learn and teach people how to be good, because it doesn't happen automatically. and then the people who want to and who are able to, because it varies at different times of your life, doesn't it? Mm-hmm. can take that. But we need to be there to make sure the feedback and the coaching is in place as well.
Yeah, absolutely. And what's really interesting is I'm thinking back to when I was a registrar, early registrar years. I didn't really know about this sort of stuff. So yes, you put the effort in to pass the exams, but coaching, feedback, deliberately chasing, following up patients wasn't natural, and nobody told me to do it. So it's, that's definitely something I want to signpost everyone to that paper, because it sounds really interesting. And I will put the reference to that in the podcast notes, actually. Really, really interesting. I think the key thing that I do try to get any trainee to do, any doctor, is to follow up patients, because if you don't follow them up, how are you ever going to know what you did was right or wrong?
Yeah, and we learn mainly, through practicing with cases and feedback. That's how we learn to be good at clinical reasoning, practicing with cases and feedback, and then reflecting on the cases we've seen. But often you need to reflect with another person, because especially when you're learning. Yeah,
that's a really good point. So we do try and have case discussions as sort of around the table at lunchtime, where we do discuss cases. But what we often do, and we probably shouldn't do as much, is we discuss the interesting cases. And sometimes we should just discuss the patient with abdominal pain, the person who comes in with chest pain, because their learning points are just as rich from those cases as the encephalitis, the autoimmune encephalitis that everybody seems to have. And I don't think I've ever seen it. So, okay, moving on then. Obviously, clinical reasoning is the key to working as a physician. I think it's one of the most important things, in fact, the most important thing as a physician.
It's the point, isn't it? It's the point.
Exactly. And I often say, if you're going to be doing a knee operation, you're taught how to do the knee operation. As physicians, we're making diagnoses, we're thinking, but we're not taught how to do it. And explicitly taught how to do it.
Yes, that's right. It's not explicit. It's not systematic, and it's not explicit. And that's partly because we do now, hopefully, but we never had a language. We never had a shared vocabulary. We never had a shared language. And one of the things that we're trying to do with CREAM, which is the Clinical Reasoning and Med Ed group, is just give people resources. And one of the things we talk about is, just learning about clinical reasoning concepts alone doesn't make you better, but it's important because it gives you a shared vocabulary, a shared understanding, so teachers and learners can talk to each other.
Yes.
Because if you don't know what a problem representation is, or if you don't know what an illness script is, or whatever, then we can't talk about it and learn from it. So we're really trying to we need that common understanding, what clinical reasoning is in a way that helps us as teachers. Because what's really fascinating is, to me, all GPs, consultants, and specialty doctors, people who are not in training, well, we're all learning, aren't we? But those of us who are teachers, let's say, we all know what clinical reasoning is, in inverted commas, but actually, to be able to teach something, you need to be able to break it down.
Yeah.
And that's the problem. So my job is to help people break it down. So, because a lot of the teaching happens in these really small conversations on the shop floor, like you said, micro teaching. It's just the little clinical conversations that we have about patients all the time during the shift. And some of them can just be, if you're teaching just a little, but often people feel like they're really learning. It doesn't have to be a big thing, but we all need to have that language.
So I'm back at work tomorrow. I'm going to be working on a medical decisions unit. So high turnover, lots and lots of patients coming through. What can I do to, I guess, teach clinical reasoning to who I'm working with tomorrow? How can I make sure they leave tomorrow shift going, that was really interesting, I learned something today? What key tips can I do on call, on the shop floor, when it's busy?
Well, do you know what? You've asked, that's a big question.
I know.
Maybe another podcast. But what's really fascinating is there are some teaching strategies that are better than others at improving clinical reasoning ability. And the good news is that the ones that are most effective involve the learner doing most of the work. Because teaching is hard work, because, talking all the time is hard when you're trying to also see patients. And so one of the things that's, I mean, there are lots of different ways, but I think, well, I don't know where to start with that question, but instead of you explaining, I'm just going to give you one example.
Yeah.
Get the learner to explain. So it's called self-explanation. So when you get someone to talk out loud and explain it to themselves for the purpose of increasing their own understanding, that outperforms explanation by the teacher. So, and it only works when the case is relatively complex, not if it's dead simple. But if you get the learner to explain it out loud to themselves for the purpose of increasing their own understanding, instead of you explaining, their learning is better. And there's been meta-analyses on this. This is what you already see, Amy, because it's when the SHO comes up to you and says, can I just discuss a case? And then they talk out loud everything about the case, and then they go, oh, it's okay, I know the answer now, thanks, and they walk off. So they're doing it. Yeah. So what you can do is you can prompt this by, and I do this in a very simple way. I just say, what do you think?
Yeah.
And I'm not being annoying or deliberately, I'll just say, what do you know? So they say, oh, I don't know what to do about whether I should do this, that, and the other. And I'll say, what do you think? And you might expand on that and say, explain it to yourself or something. And actually, when they talk it out, they will often come up with something really sensible. And then you can either say, yes, that's great, or you could correct a mistake, because there might be. So here's a beautiful example. F1 came up to me and said, I don't know whether to start this. Well, an 86-year-old woman, she's come in with a fall, no chest pain, ECG normal. Someone's done a troponin. It's 40. So it's moderately elevated troponin, because less than 14 was our cutoff. Shall I start it on treatment for ACS? Yeah. And I said, let's think about what you've just said. What do you think? And he said, well, she had no chest pain. Her ECG is normal. She's literally come in with a 4. I think it was in the garden or something. I don't think she's had an ACS. And I said, yes. Did you know that if you're over 75, 50% of you will have a moderately elevated troponin just because of your age? And he said, I didn't know that. Thank you. And he walked off, and that was it. So you just have getting the learner to commit is actually really powerful as a teaching strategy, instead of just explaining to them or answering for them. As long as you do it in a nice learning way, not in a horrible beat you over the head way.
Yeah.
And then it also allows you to assess their understanding and correct any mistakes as well. So if I just give one tip, self-explanation is more powerful than explanation by the teacher.
Brilliant. And it's something that we can all do at work, isn't it?
And it's not tiring for you, because
Yes.
they're doing all the work.
Yeah. And often when you do that, the trainee will come up with a diagnosis or something I hadn't even thought about. I'm like, oh, that's a really good thought. Thank you very much. So then both of you are learning, because what I often say to trainees as well is we learn just as much from you as you learn from us.
Yeah.
So every day I go to work, I try and learn something new. Or it might not be something new, it might just be reminding myself of something I used to know and it's somewhere far back in my consciousness and it's just made me rethink about it. And that's really, really important. Thank you so much. That was absolutely fascinating. I always make notes on podcasts and I've made 9 pages of notes.
Oh my goodness. That's great.
I know. So I've done a lot of learning today. So and I think we probably do need to do another episode basically on how to teach clinical reasoning at work. Because it is such a huge area, isn't it?
Yeah, there's lots of evidence now about things that work. Some really cool stuff that I'd be happy to share. Yeah, that I've been practicing with. Yeah,
that would be amazing. Thank you so much. So thank you so much to all the listeners out there listening to today's fantastic podcast. If you could rate, review and share the podcast with other people, that would be amazing. A massive thank you to Nicola Cooper for joining me today, and I'm sure she'll be back soon. Thanks for listening. Goodbye.
Bye-bye.
You've been listening to the Home of Medicine podcast, a podcast brought to you by the EFIM Academy in association with the European Federation of Internal Medicine, a leading organisation in internal medicine. Thanks for listening.